Hi, my name is Rachel Jensen, and I am a student at Shaker Heights High School. This summer, I participated in the Science Internship Program with Dr. Marco Martua in anesthesiology. My project is titled Anesthetic Challenges During Neurosurgical Procedures Using Intraoperative Magnetic Resonance Imaging Systems, Literature Review, and Case Report. Intraoperative magnetic resonance imaging systems, abbreviated as IMRIS, is a new concept that combines traditional MRI technology with the operating room setting. First developed in 1994 at the Brigham and Women's Children's Hospital in Boston, Massachusetts, IMRIS allows surgeons to visualize and evaluate target tissues during the operation. It is often used in neurosurgery in the excision of brain tumors. However, its use presents challenges to the anesthesiologist. This is a picture of the IMRIS scanner and operating room, which differs from the traditional OR setup. The prone position is common for patients undergoing neurosurgical operations such as those performed in IMRIS. In this position, the patient is face down, as opposed to in the supine position where the patient is lying on his or her back. The prone position is also associated with potential anesthetic complications. This case study details the anesthetic management of a patient undergoing a craniotomy in the prone position at our institution using IMRIS. The case discussion will evaluate conditions that may complicate anesthetic management during surgery involving IMRIS and the prone position. This case involves the treatment of a 30-year-old female patient weighing 124 kilograms with no known allergies. In 2006, she was diagnosed with a recurrent left parietal glioma and had 2 surgeries in 2006 and 2007. The patient was undergoing a repeat left parietal craniotomy for resection of the brain tumor. The operation was to take place with the patient in the prone position using IMRIS. Prior to induction of anesthesia, a list with the different non-MRI compatible medical instruments and devices was reviewed, checked, and signed by the anesthesia provider to ensure the placement of these devices in a safe location once the MRI scanner entered the OR. Induction of anesthesia took place outside the operating room in a specially developed induction room, equipped with an anesthesia machine and portable monitors to transport the patient into the procedure room. An arterial line was placed in the right radial artery. 2 IVs and a Foley catheter were placed as well. Pre-operation vital signs were taken by the anesthesiologist, indicating that the patient was in stable condition. After a stable induction of anesthesia with rocuronium, midazolam, fentanyl, and propofol, the patient was successfully intubated. The patient was then moved to an MRI-compatible bed to avoid the presence of any hidden metallic instruments and then taken into the OR after being scanned with the MRI wand. Once in the OR, the patient was placed in the prone position with the head secured in a 3-point fixation device, facilitating venous drainage, spinal alignment, adequate padding of pressure points, and patient immobility. Unlike in a traditional OR, the head holder was already attached to the surgical bed. This proved to be a challenge since pinning was performed when the patient was already in the prone position, and the head holder differs from the Mayfield head holder used in a regular OR. Anesthesia maintenance consisted of isoflurane and rocuronium and remifentanil infusions. After sterile preparation, the prospective site at the Vone flap was located and opened, and the tumor was immediately found. The IMRIS, a Siemens Esprit MRI with 1.5 Tulsa of power, was used 3 times to verify tumor location and size. A reviewed list of non-MRI compatible instruments was checked prior to each MRI usage. Also before IMRIS use, the surgical field was temporarily closed at skin level and completely covered with a sterile plastic covering that prevented patient visualization. Here are some of the MRI scans taken of the patient during the operation. After the tumor was removed and the site fully closed, the head was removed from the fixation device and the patient was returned to the supine position. The patient was successfully extubated and awakened and was removed to the post-anesthetic care unit in stable condition. She was discharged from the hospital 4 days later. IMRIS offers several clear surgical advantages. By generating high-resolution images of the procedure, IMRIS provides accurate and up-to-date information with which the surgeon can reevaluate procedure course. This improves the extent of glioma resection because surgeons can ensure complete tumor excision before closure. IMRIS allows detection of the location and margins of brain lesions and brain shifts that occur during the operation. Finally, surgical risks, operation, and recovery time, and the need for repeat surgery are reduced. Despite these surgical advantages, MRIS provides several anesthetic challenges related to the special OR bed setup and the presence of a magnetic field. Unlike the pinning in a neurosurgical suite, which is accomplished by placing the Mayfield head holder before the patient is moved to the prone position, in IMRIS the head holder is almost always already attached to the surgical bed. Although the holder can be removed, the surgical preference is for attachment in the prone position because the multiple parts cannot be easily aligned and attached. The fixation device in IMRIS also differs from that in a typical OR setting because it is limited to angular as opposed to lateral displacement. These circumstances make it more convenient to pin the head following movement of the patient to the prone position. However, this complicates airway management of the patient. In addition, fixing the head in this fashion places the patient at risk for eye injury. At least one member of the anesthesia team should hold the endotracheal tube and monitor for patient pin displacement, especially into the patient's eyes. Besides potential IMRIS-related complications, other complications that may arise from the prone position include peripheral airway obstruction, nerve injuries, ocular injuries, pressure injuries, cervical spine injury, and hemodynamic instability. The anesthesiologist has limited patient access and visualization in the prone position. The prone position also makes positioning in the IMRIS scanner more lengthy and difficult. The presence of a magnetic field requires special safety and equipment considerations by the anesthesiologist. Every magnetic object within the electromagnetic field will be attracted to the magnet at high speeds and can produce injury to the patient. Therefore, all anesthesia equipment should be accounted for and cataloged separately before the scanner is used. Non-MRI compatible equipment must be removed to the designated area. There is a risk for severe thermal injuries resulting from direct patient contact with metal electrocardiogram leads, non-MRI compatible pulse oximeters, or wires which may overheat after exposure to the electromagnetic field. Even the colored tabs on eye protectors must be removed to prevent patient burns from the contained dye. It should be recognized that while under anesthesia, the patient cannot respond to painful stimuli, such as intense heat. Furthermore, patient temperature cannot be monitored during the scan. Specifically during IMRIS cases, to keep the patient sterile during the scan, a sterile plastic drape is slid around the patient, preventing visualization and easy access to the airway. The scanner itself is an obstruction to patient access and visualization. If an airway complication such as extubation occurs, it takes approximately 20 to 30 seconds to remove the MRI scanner and the plastic covers to gain airway access. At that point, placement of a laryngeal airway mask would be advised since direct laryngoscopy would be very difficult to perform since the head holder prevents surgical spine extension. It would be noted that in an emergency situation where a defibrillator is needed, it can be brought into the OR only after the MRI scanner leaves the surgical suite and is locked into the holding bay, a process that takes at least 90 seconds. Finally, electromagnetic interference with pulse oximetry and EKG tracing is a common occurrence. Our goal was to review the most common critical anesthetic complications associated with the prone position in IMRIS and the presence of an electromagnetic field. Anesthetic management of a patient in the prone position during a procedure using IMRIS is very feasible if appropriate precautions are taken. Equipment must be properly managed, and anesthesiologists must be well trained and equipped to deal with potential complications. Special thanks to Dr. Marco Mortua, my peer mentor Patrick Finnegan, Rocky Paul, and the Office of Civic Education Initiatives. Thank you.